Okay, here we go with lesson C in 150, the assessment and treatment course. We're going to talk about hypovolemic shock. We're going to define it, talk about assessment, and then what to do about it. Definition of hypovolemic shock is fairly straightforward. It is what it sounds like. It's loss of volume, low volume shock. This can be due to bleeding, or it can be due to volume loss from other things like vomiting, severe diarrhea, even severe sweating and dehydration. So why is loss of volume even a problem? Well, volume loss from bleeding includes a loss of red blood cells. Red blood cells are what carry the oxygen. So if we don't have enough of those, we can't carry enough oxygen. Another huge problem is the decreased volume causes just a decreased pressure in the system. So patients will attempt to compensate for that with vasoconstriction, with elevated heart rate, but at some point that can be overwhelmed by continued loss in volume. The other thing is on the cardiac side, on the heart side, that lower volume equals reduced preload. There's less blood coming back to the heart. A reduction in preload equals reduction in stroke volume. If the heart's got less blood coming back to it, it's going to have less blood it can pump out. Even by increasing the rate and increasing contractility, if there's just not enough blood there, just can't pump it out. So reduced cardiac output occurs, which eventually results in a reduced blood pressure, unless that heart rate or the vasoconstriction, the systemic vascular resistance, the SVR, unless the two compensation mechanisms can keep up. So volume loss hits us in an oxygenation standpoint, an overall pressure drop, and a reduced ability to pump. How do you assess hypovolemic shock? A key point here, and when I say key point, think about readiness check, think about ask you this over and over, but a key point here is that shock and hypotension are not the same thing. If I give you a scenario and I tell you the patient is an elevated heart rate, has cool, pale, clammy skin, which should mean to you that he's vasoconstricted, he has an elevated respiratory rate and he's got some altered mental status, he's a little confused, a little anxious, not talking about decreased level of consciousness where he's only responsive to voice or responsive to pain or unresponsive. We're talking about alert but altered, anxious, a little bit confused potentially, which can be from many, many things. But when your patient has altered mental status, elevated respiratory rate, elevated heart rate, tachycardia, and has those skin changes that should clue you into vasoconstriction. The skin is cool, the skin is pale, the skin is moist. When all those are present, the patient's in shock. I don't care what his blood pressure is, he's in shock. So you can have a blood pressure of 120 over 80 and still be in shock. You're just still in compensated shock. Once that hypotension shows up, now you're in decompensated shock. So what do we do? What do we do about loss of volume? Well, we need to control that external bleeding as much as possible. We'll talk about that here in a second. Control the internal bleeding as much as possible. That's probably going to need to be done in surgery in a hospital, so rapid transport becomes a key technique for dealing with internal bleeding. Try to replace that lost volume with the best thing you have. I sure wish we had blood. We don't. We're stuck with crystalloids. There's issues there, but it's all we've got. And we need to try to start catching up as quickly as possible before these patients go kind of over the hill into into decompensated shock and it becomes irreversible. Usually these patients are going to require urgent transport. I can't think of a hypovolemic shock patient that doesn't require urgent transport. And then we need to also remember to not be distracted by just the bleeding problem, just the hypovolemia problem. It's CVO, circulation, ventilation, oxygenation. So the circulation problem is potentially distracting. Don't ignore ventilation and oxygenation. We need all those red blood cells packing all the oxygen that we can get for them. So in Lab C, we're going to talk about how to control external bleeding, and we're going to talk about how to replace volume. We're going to use direct pressure, talk about various types of tourniquets, and go quickly through elevation and pressure points, which are kind of the old way, but there are points in the current setting where those are valuable. A little bit about splinting and some volume replacement. Direct pressure. Direct pressure deals with external bleeding if you will directly press on what's bleeding. If you've got a mound of 4x4s and a whole bunch of gauze and you can't really get direct pressure on the bleeding vessels, you don't have direct pressure. You have indirect pressure, and so indirect pressure is not part of this. Direct pressure, fingers pressing on bleeding. It may be that when you arrive, the first responders have done the best they can to attempt to control bleeding, and there's a fairly large, bulky dressing on the wound, and it may be necessary for you to unwrap all that, get through all that, and get right to the bleeding, assuming you can get some gloved fingers pressing on the arterial bleeding. Arterial bleeding is going to require more pressure and for a longer amount of time than does venous or capillary. Arterial bleeding, of course, is red and spurting. Venous and capillary are more of a flowing and oozing. We still want to use direct pressure no matter what, but just realize that if it is an arterial bleed, you're going to need to push on the artery, and you need to continue direct pressure and add a tourniquet. It isn't that we just stop doing direct pressure and switch to a tourniquet. We need to add the tourniquet to it. Tourniquets are great when you use them in addition to continued direct pressure. We want that extremity tourniquet to stop the inbound blood flow. We don't want arterial blood flow coming in, so make that pulse go away. You don't crank the tourniquet down until the bleeding stops. You crank it down until the pulse stops. You may have to use more than one tourniquet. Nobody said you could only use one. The optimal placement is somewhat up for debate, but you need to stay off the joints. You're trying to get placement of that tourniquet where it can squish an artery against a bone. Probably you can get that just above the wound, just proximal to the bleeding site. You may be able to get a pretty good squeeze from your tourniquet. If not, you're going to need to add a second one and maybe move it around a little bit. When you add a second tourniquet, a lot of times you just go right above the first one, and that may work, but again, stay off the joints and realize that if you're not pushing on an artery, if you're not squeezing an artery with that tourniquet, you're not getting the effect of the tourniquet. Junctional tourniquets are for situations where you have a significant bleed at the junction of an extremity with the trunk. So a junctional tourniquet would be great for the groin or the axilla if you have them available. I don't think a lot of services have them available. We have one in our show and tell box that we'll show you and let you play with it. And basically, the concept is a blood pressure cuff type device that you inflate and put some pretty significant pressure directly on what is bleeding. So again, if you don't have the junctional tourniquet, then you're going to need to be able to do direct pressure. And you may tie up one or more people just doing the direct pressure, but this is what matters. Stop the bleed is what matters. And we can't think of a reason why you would take a tourniquet off in a normal field setting. Maybe perhaps in a wilderness or some austere environment. I don't know. I can't come up with a good scenario for common field EMS in our world where we would even talk about taking a tourniquet off. So don't hide it. Make sure everybody knows it's on there. Be good to know what time you put it on there, more or less. But the purpose of the tourniquet is to stop the bleeding. And if it's not getting that done, you need to move it or add another one to it. In the olden days, not too long ago, we used pressure points. That was pushing on an artery where it went over a bone. It certainly makes sense. I mean, that's really kind of what the tourniquet's doing now. Nobody said you can't use pressure points, but what we are saying is that don't be distracted by that. Don't think it's going to work. Use it as an adjunct, but not as a primary treatment. Same thing with elevation. It's okay to raise an extremity and use gravity to your advantage, make it harder to pump the blood out. But don't fool around with that after you've done direct pressure and you're like, well, I'm going to do elevation before I add a tourniquet. When direct pressure is not working, add a tourniquet and then reevaluate whether you're really doing direct pressure or you're doing, in the area indirect pressure. Splinting is a good thing. That can help reduce some of the internal blood loss. I don't think it's going to stop it, but it can help reduce some of that. So splinting is always good. Your patient should feel better, should reduce some pain. Be sure you check that distal CMS. Remember that if the patient's significantly hypovolemic, You may not even have a distal pulse to start with. So it isn't that your splint made it worse, it's that it was bad to start with. And then use appropriate splints. Critical patients get simple splints. The more complex the patient, the simpler the splint. So a long spine board or something very quick. And many times the splinting is done as transport is being initiated. So splinting is a good thing, but let's don't sit on the scene messing around with a splint with a guy with several fractures that are continuing to bleed internally regardless of what we do with the splint. Then you need to try to replace the lost volume. Yes, I wish we had blood. Blood is best. People do best when they have their own blood in their own body. The second best thing is somebody else's blood in their body. The maybe third, fourth, or 27th best thing is crystalloids, normal saline or lactated ringers. It's all we've got. The crystalloids don't take up the same amount of space. It takes about 3 drops of crystalloid to take up the same physical space in the vascular system as a drop of blood. And the problem is that none of those drops of crystalloids carry any oxygen. So you need the red blood cells to make this whole thing work. And stopping that blood loss is key to keeping enough red blood cells still in the body. Stop the loss and then do what you can to replace what was lost. But the problem is that crystalloids not only don't take up the same amount of space and they don't carry any O2, they also disrupt and dilute the whole clotting mechanism process. They're rarely at the same temperature as the patient's body, and so now the patient's having to expend calories, burn energy, trying to stay warm. Hypothermia kills trauma patients. Messed up clotting mechanisms kills trauma patients. And then, unfortunately, neither normal saline nor lactated ringers are the same pH as your patient's body. And so they are relatively acidotic. Saline worse than LR in terms of its acidosis. And so a little bit of these may be helpful, but a whole lot of them, not so much. And we'll use what we can because it's all we've got. So, quick summary. Stop the loss, replace what was lost. This is not rocket science. Go fast, do things that matter. Optimize that patient's oxygenation and ventilation. Make sure that we're getting an appropriate amount of oxygen to the alveoli so that whatever red blood cells are left going by can be fully loaded. And we can do what we can to temporarily impact this until a real fix for the blood loss can be effected and real replacement with real blood can be instituted. Other big thing, don't wait for that BP to drop. Your patient's in shock based on an assessment that does not need a blood pressure. Now, certainly, if they don't have peripheral pulses, you can estimate that the blood pressure is dropped, but you don't need an absence of peripheral pulses for you to say the patient's in shock. If they are altered mental status, they're a little anxious, a little confused, a little scared, if they have tachycardia, if they have tachypnea, elevated respiratory rate, and they have cool, pale, clammy skin, they're in hypovolemic shock, regardless of what their blood pressure is. And then try to replace the volume as best you can. Probably ought to hold up or think about it or call and talk to somebody when you get a couple of liters in. The issues with crystalloids have to do with the amount of crystalloids that a person gets. A bag of saline or 2 bags of saline is probably not a big deal. 3 or 4 or 5 bags of saline may be a big deal. And so a lot of protocols these days are saying resuscitate the patient until the signs of shock go away. And until you have accomplished that, you keep giving saline up to a point. We like to stop at the 2-liter mark and call and talk to somebody. So hypovolemic shock, we'll deal with it in Lab C.